Can you hear me? Can you hear me?
Yeah, we can hear you.
Good, excellent, thank you.
Hey, this is Rochelle.
Good evening. I'm Dr. Kenesha Zimmerman. I am really pleased to welcome you to COVID-19 in the classroom. Tonight, we'll be talking about COVID-19 and the flu. We have Dr. Mike Smith, Dr. David Weber, and Dr. Ibakun Akinboyo, who will be presenting and serving as our panelists. And as usual, I am very pleased to share the stage with Dr. Danny Benjamin. Danny?
Thanks, Kenesha. So just as a reminder for folks about format, we will have our panelists present during the first few minutes of the discussion today. Then we'll take questions from folks. You'll recognize some of your questions from prior webinars for those of you who've been tapping in questions, because if we don't get to your questions during a webinar itself, we'll push them out to either a frequently asked questions document or put them into a future webinar. We'd like to get as many of your questions during the webinars as possible, so please go ahead and type those in as we go along. The link to the YouTube live stream is going to continue so that you can view this webinar again at your convenience. That's also going to be located for many of you within your school districts, and these materials will be on the ABC website next week. I think with next slide, we can go to, don't forget to fill out your post-webinar survey. For many of you, that's how you'll get credit for your continuing education credits that many of your school districts are offering you for participating in this. Go ahead, next slide, please. And I think it's Dr. Smith to start us off. Mike?
Yep, thank you. So we're gonna start with just some basics. What is flu or influenza? Flu is a common virus that infects the respiratory tract. It's actually very common. Somewhere between 40 to 50 million Americans get infected each year. The good news is that it rarely requires medical labs or imaging, although you can get quite sick. We'll go through some of those numbers here in a little bit. If you are unfortunate enough to get infected, your symptoms can last several days or weeks. Now, the good news is, unlike COVID, this is a vaccine preventable disease. However, like COVID, it is transmitted through droplet exposure. Next slide, please. So I mentioned some of the numbers. These are data from the last influenza season. So every year flu starts in the late fall and goes through late winter, early spring. So looking at numbers from October 2019 through April 2020, the CDC estimates 39 to 56 million illnesses due to flu. Of those, 18 to 26 million medical visits. Again, most of these occur on the outpatient side. You can see 410 to 740,000 hospitalizations due to flu. And again, while it tends to be fairly mild for most of us, for people who have high risk factors, it does cause death, with an estimated 24 to 62,000 deaths in the 2019-2020 flu season. Next slide. And I think Dr. Akinboyo, these slides are for you.
Thank you, Dr. Smith. So this question comes up, it has come up for COVID-19 and certainly applies here as well. And the question is, who's at risk or high risk for severe illness? And in this context, we can think of severe illness as either having a high risk for comorbidities or being likely to need to be in the hospital, so being hospitalized for flu or COVID. And I think there's some similarities here. For adults, we've mentioned before, older adults, people with certain underlying conditions, and we can talk about the specifics of this as we go on. And certainly pregnant women. I think we've said at different points that we have a lot to learn about the impact of COVID-19 in pregnant women, but we know a lot about influenza. And we often recommend that pregnant women are protected and stay in a cocoon of protection, usually with vaccination. And then for children, again, we have a lot of experience knowing what could lead to severe illness from flu. The risk of complications for healthy children for flu compared to COVID-19 are especially notable in young children. So children less than the age of 1, we often see that they have a higher risk of being hospitalized with flu. And those with chronic medical conditions, again, we can get more specific as we go on today. For COVID-19, I think the one thing to note about the caveat here about children would be that we've seen a higher incidence, so we've noted it more often in children that are in the school age category, so about 5 to 10, seems that they're more likely to develop this inflammatory syndrome after COVID-19 is diagnosed, the multi-system inflammatory syndrome in children, MISC. Next slide, please. Just a brief reminder again for those that joined us later to complete the post-webinar survey and certainly let us know about your attendance. Next slide.
So what are some differences between COVID-19 and flu? I guess if you're a microbiologist, you can see there's some clear differences in terms of the proteins and the way the viruses are built. Next slide, please. However, for those of us who are not in the micro lab, even for us as infectious disease physicians, certainly for people being out in public and as teachers and superintendents, it's really hard to tell these two viruses apart. They're clinically look very similar. So both of them can give you fever, cough, shortness of breath or difficulty breathing, fatigue, sore throat, upper respiratory symptoms like runny or stuffy nose, muscle pain or body aches, headache. Things like vomiting and diarrhea have been reported for both of these viruses, though typically more common in children than in adults. And again, I think probably the biggest difference between these two viruses is that flu is a vaccine preventable disease. And you may see this in the news. The CDC does mention that loss of smell may be more common in COVID-19 than flu, but that's not really a big clinical difference. Next slide.
So another question we get quite often is, can you get COVID-19 and other respiratory viruses at the same time? So just alluding to the last slide that Dr. Smith went through, we can't really tell the difference other than the fact that influenza can be prevented by vaccine. And the reason why this question comes up is when you test, if you're testing for COVID-19, should you be testing for other viruses and does it matter? So this group from Chicago, 2 large-based Chicago hospitals, just reviewed their experience in the early part of the pandemic, testing pediatric patients that had symptoms to see how many of them potentially had COVID-19 and another respiratory virus. And you see the second row here was just assessing the number of kids that were positive for any respiratory pathogen. And about 12%, a small number here, 16 had SARS-CoV-2, which causes COVID-19. About 12% of them had another respiratory pathogen. But as you can see, if you go to the next column, 38% of those that didn't have SARS-CoV-2 had something else. So common things being common, there are lots of viruses that get transmitted, particularly during influenza season, and we're more likely to see those usually in a typical year because kids are in school, kids get colds. I don't know what this year will look like, and we'll address this in another slide. The last row here was just showing influenza and RSV, respiratory syncytial. The reason we pull those out are because in pediatrics, those are the viruses that tend to be associated with severe illnesses. So being admitted to the hospital or having some worse clinical illness. And you can see the numbers are again small. They only saw 2% of those that had SARS-CoV-2 also had RSV or influenza. And then of those that were negative, there's a larger number of them that have RSV or flu. I think all of this to say the numbers here are skewed because this was in the beginning of the pandemic, March to April. And you could argue that we actually were not testing as often as we would. And that may have affected how often we picked up on these viruses. But co-infections are possible. You can have COVID-19 or SARS-CoV-2 and another virus. It's just not very common. Next slide, please. Just going into another question we often get is, so how do you protect yourself against influenza? And I think this actually is linked to protecting yourself against COVID-19 and alludes to a lot of the things we've already talked about. So prevention of COVID-19 and flu can occur by wearing masks. Historically, we haven't actually pushed for people to wear masks in the community, so this is a new habit, but it does seem to help with preventing other respiratory viruses and not just COVID-19. And of course, some respiratory hygiene. Typically, it's coughing away from people. Preferably, if you're coughing, you should be staying home, but coughing into the crook of your elbow. Constantly and frequently washing our hands, particularly if you've left the house or your primary area of residence, if you're interacting with other people, if you have to cook food, things like that, just building it into your day. Staying home when sick, I think even prior to the pandemic, this should have been a core part of our behavior, but I think the pandemic has made this much more important, and limiting or having some kind of physical distance within our communities would limit COVID-19 and to an extent, of course, limit the spread of influenza. Next slide, please. We actually saw this play out locally. So in North Carolina, again, the context here is we certainly were likely not testing as often as we would in other seasons, in other flu seasons. And then I just want to point out that this may underestimate all of the other viruses that float around. We know kids get viruses, it runs through them and they get better without us testing. But what this graph is showing is the number of positives on the y-axis and then time on the x-axis. Flu season typically runs from just about October, so we're hitting it. Getting your flu vaccine now is timely. October to just about the end of April. I think this graph actually goes to May. And you can see this sharp decline in the number of cases of the flu influenza that were detected. Note that flu is the red line here. Even though flu season technically continued for a little bit, we saw a massive drop. Some of it testing, but also just staying home. Next click, please. I will point out though that when you look across the year, so compared to prior years, unfortunately, we still saw a lot of deaths associated with influenza. So we have a lot of history with influenza. We know exactly what it can do. It is still one of the infections that we push to prevent because there's still a lot of concerning both death and comorbidities afterwards. Next slide, please.
So why is it important to get a flu vaccine every year? Just to point out, I think all of us on the call in infectious diseases, actually to work at Duke, you have to get your flu vaccine every year. Even before that, most of us in infectious diseases did get our flu vaccine every year. I bring my kids as soon as it comes into the office, and my wife gets her flu vaccine too. It's important to be vaccinated every year because the viruses are constantly changing, and the vaccines do change slightly from one season to the next season. And we'll hear a little bit about what's going on in the Southern Hemisphere, but the really cool thing is that based on what's happening in the Southern Hemisphere, we can get a sense of what strains of influenza should be in the current year's vaccine here. Some other exciting news is that there is research being done on a universal flu vaccine. So hopefully, like the other vaccines that we get during our childhood, maybe one day soon, we'll be able to get a single or once every 5 years flu vaccine, but we're not there yet. The other thing to note is that your protection from a flu vaccine does decline over time. And when you put all these things together, it's clear that yearly vaccination is needed to maintain your best protection. Next slide, please. And these are just some examples from not this past year, but from 2018, 2019. So overall, in the entire US population, just under half of people chose to get a flu vaccine. So even with only half of the population being vaccinated, you still saw a 4.4 million decrease, 4.4 million person decrease in flu illnesses, 58,000 fewer flu hospitalizations, and 3,500 fewer flu deaths. Again, just to point out, I remember I may have said before, there's between 40 to 50 million cases of influenza each year. Now, the vaccine is not necessarily going to prevent it, but it is very effective at preventing severe disease. Next slide.
So question one, are we anticipating a less severe season based on what occurred in the Southern Hemisphere? And the answer is yes, coming up on the next slide. So of course, our winters are the Southern Hemisphere summers and vice versa. We see respiratory viruses and ultimately likely COVID more in the winter season for several reasons. One is these viruses survive better at low temperature and low humidity. Of course, in the winter, we're indoors more, putting us more at risk. And we heat our houses, which dries out our mucous membranes and makes us more susceptible. So what was the experience in the Australian, has been the Australian winter? Well, you can see here in the dotted and dashed lines how they have quite a bit of flu, not surprising. But look at in past years, but look at the bottom. In the current year, you can see here as they began introducing COVID mitigation efforts, suspending flights, hotel quarantines, preventing mass gatherings, mask wearing, physical distancing, they've seen a tremendous decrease in influenza. Now let's go halfway around the world to South Africa. So you can see here in South Africa, much the same story that in past years, of course, as they're in their winter, a substantial amount of flu activity. Of course, they went into total lockdown, closed businesses, university and school grades opened there. But again, very low levels of influenza. Now, the question really is, will that be mimicked here in the United States? Next slide. And the answer is, we really don't know. But if we practice the same things that have been practiced to prevent COVID and have been done in the Southern Hemisphere, physical distancing, hand washing, mask wearing, and of course, we still should take our flu shots because even though there may be much less flu, given the millions, tens of millions of people who get flu, we certainly want to decrease that. So we might see substantially less influenza here. Importantly, flu, as we already said, is transmitted very similar to COVID, short distance droplets, direct contact, to some extent indirect contact, such as touching a nose and touching an object. Someone touches that object and rubs your nose, but the same prevention will work to prevent this. So we're hoping that if we do the same things to keep COVID at low levels in the winter months, we will also have much less impact on flu, meaning children not having to stay home because they have flu and teachers not being sick. So all of those are a good thing. But again, I want to emphasize, you still need to get your flu shots. And like Duke, flu is a condition, flu shots, a condition of employment at UNC.
Great, and I think there's a follow-up question either for Dr. Akinboyo or Smith on the clinical differences between flu and COVID. So how will we be able to tell the difference, or does it matter? If they are sick, don't they just need to be at home for how long? Dr. Akinboyo, Ibukin, do you want to pick this one up?
Sure, I think we can probably tag team on this. And there's one more slide which we will go back to in a second. But the short answer is, if you're trying to differentiate between COVID-19 and influenza, you really can't based on symptoms. That's why we test to delineate which one is which. That being said, I think in practice, particularly this year, all colds should lead to a child being removed from a congregate setting, potentially tested, but at least staying at home. As to the specific guidance, should they be home for 7 days, 10 days, 14 days, depends on the test results. I think a lot of those nuances can be worked out, and NCDHHS has done a great job in trying to send out some guidance for schools, but we really can't use symptoms to tell the difference between both infections and with a lot of respiratory viral infections, because children tend to have milder COVID-19 symptoms. Dr. Smith, if you have anything to add.
Yeah, and this is where I think educating your students and their families, you're probably not going to get sick during the school day. I think you'll know the night before or the morning of school if your child is sick or if your students are going to be sick. So the importance of, going through those symptom checkers and making sure that families and students know that if they have any fever or respiratory symptoms, they should not come to school that day.
This is David. I'd like to make a comment. We've just built our testing algorithms for the medical center, UNC Medical Center. And if people come in to see us in clinic with signs and symptoms, because you really can't distinguish between COVID and influenza, and we do have drug therapies for influenza that we would certainly use on individuals who are at high risk for complications. And in fact, it's open to anyone who wants to cut a few days off their illness, that we will automatically be doing testing for flu and COVID simultaneously. And the diagnostic companies develop tests that do both at the same time.
Yeah, thanks for that, David. I think that'll be more and more common this year throughout the community, throughout the healthcare systems. Dr. Zimmerman, I see that you took yourself off mute. Go ahead, Kenesha.
I wanted to ask Dr. Smith, you mentioned that we should get vaccinated. Tell me more about what we know about the efficacy of this year's flu vaccine. Do we know?
So we haven't seen, again, you know, the standard answer for this is what happened in the Southern Hemisphere, and does the current vaccine match what's in the Southern Hemisphere? And as we already saw, the disease is so low in the Southern Hemisphere that it's hard to know. So I don't have any, I don't have a good sense of vaccine effectiveness. I don't know if any of my other panelists do, but I've not seen those data yet, because I'm not sure, you know, what's actually going to be circulating in the United States this year.
So Mike, maybe you and our other panelists can comment on what we typically see. What's some nice round numbers? Because some people, they get into their mind a picture of the vaccine and they think in terms of, say, polio and its efficacy. Can you contrast that with a respiratory virus like flu?
Yeah, so I think you know, there's several different metrics, and I think I want to restate what I said before, which is when you have 40 to 50 million people a year getting a virus, even if you can decrease that number by half, you're talking about decreasing, you know, potential 20 million cases a year. That said, remember, the other thing is that the vaccines may not prevent you from getting the disease, but they certainly prevent you from getting severe disease and prevent deaths. So I think that's the most important thing. So, you know, let's say in a bad year, when there's a mismatch year, maybe it's only 25% effective. In a good year, it can be upwards of 50 or 60%. I mean, and that's kind of in the match of the strain. But again, I think, although I mentioned it's important to get it every year, even if it's not a perfect match, there does seem to be some efficacy. It's not really efficacy, but effectiveness in terms of reducing the severity of disease. And I think that's the most important thing.
Great. Any of the other panelists like to address that before we turn in it, before Dr. Zimmerman comes up with the next question on the board?
No, this is David. The only thing I would say is, of course, the vaccine we use in the northern hemisphere is not the same vaccine in the southern hemisphere. It gets changed for slight drifts. So we do get some idea about vaccine efficacy, but we really have to wait to see how it does in the northern hemisphere.
So while we're on the subject of vaccines, I wonder, Dr. Smith, if you might tell us a little bit about the COVID-19 or SARS-CoV-2 vaccine.
Yeah, so as you can see here, there's tens of vaccines in clinical trials of some sort. Here in the United States, there's 3 main vaccines that are in what we call large phase 3 trials. So these are the ones that have been shown to work well in smaller studies. They've been relatively safe. They generate an immune response in small groups of people. And what's going on now is there are 3 trials, one by Pfizer, we're doing that one at Duke, one by Moderna that's being run at UNC, and one by AstraZeneca, which we are going to be doing at Duke. That's the one that you may have seen in the news, was put on hold worldwide because one of the subjects had a potential vaccine-related event. We don't know for sure whether it was a vaccine-related event, but again, you have to make sure that these vaccines are very safe. So while we're waiting for additional data, that trial is on hold in the United States still. Remember, there are 2 different regulatory agencies that monitor these trials. So the FDA is still reviewing the data here in the States, but that trial has started again in the United Kingdom. So there are 3 vaccines that are in phase 3 trials. Now, typically, it takes a couple of years for a vaccine to get formal FDA approval. But as we saw with acute COVID infections, some drugs that were shown to be promising early on in trials did receive what we call an emergency use authorization. And I think we're going to talk about this in a little bit, but most of us do think that at least one of these vaccines will receive an emergency use authorization sometime in the coming months. These vaccines have been given to, in the United States, probably collectively upwards of 10,000 people so far. And apart from this one question about the AstraZeneca vaccine, they're thought to be fairly safe. The one thing that you may see in the news is that, and ideally this is probably a good thing if you think about it, but there are 2 vaccines spaced 3 to 4 weeks apart, depending on which one you're looking at. And the biggest thing so far is that the second vaccine tends to hurt a little bit more and can give you a little bit more redness and tenderness. And again, that usually suggests that you may have an immune response from the first vaccine when the second vaccine, the second dose of the vaccine shows responses like that. So very exciting. It's a very exciting time to be doing these vaccine trials. And here in the coming weeks to months, we'll have a better idea of which, if any, of these 3 vaccines are safe and generate the best immune response. I should point out they're being tested in adults first. Actually, the AstraZeneca vaccine in the UK, those trials do go down to 12. But in the United States trials so far, they're all 18 years and above for the people who are in the studies.
Before we get to some of the questions that are already in the chat, one of the questions that I get asked all the time is, well, once we get the vaccine, then what? And so I just want to outline in very broad strokes, if I had to think through some kind of best guess on a vaccine timeline, it might look something like this. And I would like for all 3 panelists to comment on that kind of timeline, a theoretical timeline, if you will, and put some context to some of the key items on the timeline. So let's say we get an emergency use authorization sometime in the winter, late 2020, early 2021. This is at the time where the trials have not yet been completed, but there's enough of a safety and efficacy signal for FDA to not approve the drug, but to allow the drug to be used in a broader population. Once that emergency use authorization comes through in the first quarter of 2021, we would most likely see healthcare providers eligible to receive the emergency use authorization. In the second and third quarter of 2021, there we're going to be seeing more very high risk folks. The details of those risk strata, those risk groups will be determined, but very high risk, the elderly, folks with other chronic health conditions, second and third quarter of late 2021. And then by the time children are eligible to be studied to receive the vaccine and children are eligible potentially to get the vaccine, we're really looking at late 2021. And so schools should be prepared to deal with and work through COVID-19, not only academic year 2020, 2021, but also 21, 2022. I'd like for all 3 colleagues to give their thoughts on that kind of broad strokes, potential timeline, and maybe add some commentary to it. And I'll go in reverse alphabetical order, perhaps. Drs. Weber, then Smith, then Dr. Akinboyo.
So let me first just sort of spend a moment and talk about how vaccines get licensed and then recommended in the US. So The drug company will present data to the Food and Drug Administration, as you've heard. They can sort of short circuit that a little bit by giving it an emergency use authorization. They will allow the vaccine to be used if they approve it based on the trial, the type of people that were used in the trial. So if it didn't include immunocompromised or pregnant women or children, it would not be licensed for that. From there, there is a group at the Centers for Disease Control called the Advisory Committee of Immunization Practices. I was a liaison member of that for 6 years. They will review that data, but they are not limited to following exactly the CDC, the FDA licensure. So they can be more strict or less strict. So they could say, well, the data shows it works in a 21-year-old, we'll license it for 18-year-olds, or this is such a severe disease and it's not a vaccine likely to hurt immunocompromised people. We don't know how well it'll work, but we'll still allow its use. Interestingly enough, under the Affordable Care Act, if the CDC recommends it, even if it's not FDA approved for that purpose, then it gets paid by insurance. And as I said, the CDC can look at any data it wants, non-US data, other data. And then in terms of using it in children, you can also do what they call bridging studies. So we may not prove that it really prevents COVID, but we know COVID is prevented by having antibodies. And so you could do a study potentially down to say age 10 or 12 or even 6 and show that children have a very good antibody response. That actually only takes several hundred children instead of thousands. And if they have a very good antibody response that's better than adults and the vaccine's safe, then they could license it even without an actual trial, which spares recruiting large numbers of children. It is faster. And in fact, they did that for the human papillomavirus vaccine in terms of the lower age for children for that. So it's very hard at this point to predict when the FDA will look at a vaccine. It's even harder to predict whether the vaccines will work. The leading candidates that you've seen actually are using a technology that's never been used in a vaccine before. They do seem to generate antibodies in early studies and be relatively safe, so we're hopeful, but we won't know until the trials are actually completed, and it's unlikely we will have a vaccine available for children, certainly this school year. Thank you.
Thanks.
Yeah, thanks, David. A couple of other comments, just building off of what you just said. I agree. I think Danny, I think your timeline is likely to be spot on. One thing that's interesting to me is, the main drug that we use right now to treat people who are hospitalized with COVID is something called remdesivir. That's been fairly well studied on the adult side. It hasn't really been studied in kids. However, the FDA did issue an emergency use authorization that goes down to children who, weigh 3.5 kilos or above without a whole lot of data. But the difference between, a therapeutic agent and a vaccine is, if you're coming to the hospital needing therapy, you're pretty sick. So you're willing to take some risks. We have to be a little bit more careful about the safety of a vaccine in young children, before we bring it to that population. And then the other thing, as I mentioned before, just to reiterate, when will this vaccine come to kids and students? I think, as we've talked about on prior calls, really it's the older children and the adolescents who seem to be at risk for disease. So you we may be seeing a situation where I would guess that older adolescents and teens may be part of this EUA before younger children do. And again, to Dr. Weber's point, the groups that make these recommendations are allowed to use data from other countries. And I mentioned at least one of those studies, the AstraZeneca study, does go down to 12 in their studies in Europe. And then finally, just while we're talking about this, in terms of these vaccines, there was a question in the chat box: are any of these vaccines kind of live attenuated? And they're not, right? They're all using technology basically to get your own body to build a copy of the spike protein that then generates the antibody response. So the vaccines that are part of the routine childhood series now, things like the measles, mumps, rubella vaccine and the varicella vaccine. Those are what I call live attenuated, where you get actually injected with live virus. None of the vaccines currently, at least anywhere close to approval, use that model.
Great, thanks.
Dr. Akinboye.
Dr. Akinboye?
I would agree. I think that we can postulate on the timeline, but the key point for us and for the audience today is that most likely and expectedly, kids are not going to be first in line to get this vaccine. So as a strategy to prevent the spread of COVID-19 and to determine the timeline for educating kids, our plans have to involve the next school year. So talking about 21 to 22, and hopefully that's it, but it may potentially bleed into other subsequent school years. The vaccine will help. Getting a safe vaccine is the goal. And so taking the time to ensure it's made safely, I get the perception that's what all these companies are doing. So the timeline, it's probably true, maybe generous, but I would anticipate at least another 2 years for kids.
Great, thank you. And potentially longer, of course, because that whole timeline depends on the primary assumption that one of these vaccines works. And although that's likely, we certainly haven't shown that yet. And so the clock really does not start in any way for any of us until the vaccine is shown to be safe and effective. Dr. Zimmerman, I think you're up.
Sure. So just taking a question out of the chat. Dr. Weber, I'll send you this one. There seems to be a lot of concern in the government about cold weather coming. Can you just tell us why cold weather in particular is of concern, and perhaps what we've learned about the virus during cold weather?
Yeah, certainly. As I mentioned earlier, respiratory viruses like flu, but also including COVID. And we need to remember there are 4 endemic already transmitting for coronaviruses that are similar in some ways, but cause more mild illness than does SARS-CoV-2. So we have a lot of data. These viruses all survive better at colder temperatures and lower humidities. So they survive better on surfaces and in the air in the winter months compared to the summer months. That's the first reason. Of course, in the winter when it's cold, we tend to spend more time inside. So we have more exposures, and we know all of the respiratory viruses spread better indoors with less ventilation, no UV light than they do out of doors. And then finally, we heat our houses. Many times we might use wood burning stoves. Those put particles into the air that make you a little more susceptible to acquiring them. But just the heat itself tends to dry out our mucous membranes and make us more susceptible to these viruses. So the combination of these, and we're really hard to tell which is most important, lead to more respiratory viral spread in the winter. So in our summer, but the Southern Hemisphere's winter, they see their viral respiratory season. And interestingly enough, if you happen to live on a city right on the equator, there is no viral respiratory season. They have low level spread of these viruses all through the year, really demonstrating that it is temperature, humidity dependent. Thank you.
Dr. Benjamin, you want to grab one?
I'll just do some house cleaning on some of the questions real quick, and then I'll turn it back over to you. So we've had folks ask about quarantining. Those questions will really be dealt with between school district, and local health department. Which is, so it's a bit out of scope for this team. We got questions about that are addressed in previous webinars about HVAC and cleaning. That webinar will be up and available. At least the presentation will, and the recording next week, and then the recording hopefully the week after that. We had a question about the use of a clear mask, and I know Dr. Weber and I were talking about this, I think yesterday or the day before. So David, this one's going to go to you. I work with deaf and handicapped, deaf and, I misread that, deaf and hard of hearing students. What are your recommendations on a clear mask? Some seem to be for sale. Are they safe?
So I'm not aware of any careful studies of the clear masks by independent people. A mask works in two ways. One is filtering the air that goes through the mask itself and adequate filtering. And the other is how tight it fits around the face so air doesn't flow around the mask. One of the problems with using a clear mask or developing one will be to try and find a material that allows air to flow through the transparent material and has to be at the same time having pores so small that it filters out the viruses. At the same time, most of these masks will not go all the way to the edge of the face because generally those materials that are transparent are not as quite flexible as cloth or paper, such that you'll get a tight fit around the face. Certainly there is enormous interest in developing these. Many people, even those who are not hard of hearing or have difficulty with speech, would just love to be able to look at other people's faces. And so there's a lot of effort there, but I'm just not aware of any independent studies yet that demonstrate how well individual clear or partially clear masks work. But I will say that data should be available in the next 2 to 4 weeks. People, including our aerosol engineers at UNC, will look at it. I do want to caution people that just wearing a face shield, which of course can be transparent without a mask under it, there's again no data that that provides a sufficient level of protection. So if you did wear a face shield, the recommendation would still be to wear a mask or a face covering underneath it. Thank you.
All right, let's see here. Let's pull some from the chat. There is a question about emphasis on cleaning and sanitizing surfaces. And there hasn't been a lot of information or a lot of emphasis on indoor air risk. Can perhaps Dr. Smith and Dr. Weber, would you maybe speak to why there might have been a shift in our emphasis, or why people are emphasizing the cleaning part of this?
Would you like me to go first? I'm happy to. So the answer is there are many studies, more than 20, that have looked at the RNA, the reproductive part of a virus, but that doesn't mean it's viable, showing that we know the virus can survive for hours to days on surfaces. We know from other viruses that, again, touching your nose, if you're infected, touching a doorknob, someone else touching in their nose can transmit it. There are more than 20 studies looking at SARS-CoV-2 RNA showing that it does get deposited on surfaces. That said and done, there are only a few studies that suggest actual transmission that way. There are a couple of outbreaks that seem to be related to different people using elevator buttons in malls or in an apartment building where they otherwise didn't have contact with each other. And one outbreak on an airplane where a woman who was always wearing her mask and everybody else on the plane was masked, but they were taking it off when they went to the restroom, as did she, may have acquired it in the restroom. But there's also quite a bit of study about SARS-CoV-2 in the air. We know that if you put it into a rotating drum, which is like a blender on its side, the virus will survive in the air for hours, but that's very artificial since it doesn't get dispersed in the air, it doesn't see UV light, and it doesn't settle because of the rotating nature of the drum. And clearly this virus is transmitted when I cough, sneeze, talk, and I'm infected to people nearby me. And we can argue a little bit about the distances of 4 feet or 5 feet or 6 feet. There are a few studies suggesting it might be a little longer than 6 feet, but there are no studies that suggest people in other rooms in the hallway on other floors, like we would find with measles or chickenpox, become infected there. Obviously, disinfection is fairly straightforward. CDC has a list of many disinfectants. This virus has a little envelope around it. It's quite susceptible to things like the alcohol you use for hand rubs, but many different disinfectants kill it. It's a little harder to look at what might prevent the airborne transmission. We know unquestionably that masks work. An example that we've talked about in the past is an outbreak that was in a hair salon where one hairstylist got infected, gave it to a coworker. We know she was infectious while they were at break, but they were always masked when they took care of clients. 139 clients were seen. And the result was there was no transmission from these infected people who continued to work while they were ill. And there are a number of excellent examples where masks clearly are protective. I will say in one recent study I read from Asia, very nice study, but if you're going to wear masks and it's going to work, you have to do it all the time. It's not like you can wear it 50% of the time and your risk goes down 50%. That study, by the way, from Asia also showed that time is important if somebody's not masked, and that hand hygiene is important. And they were all additive. That is, if you did all of those things, physical distancing, plus wearing a mask, plus hand hygiene, each one added to reducing your risk.
Thanks. That was a very thorough answer. I just wanted to add one other thing and also comment on one of the questions in the chat box, which gets to this point of why is it okay for students to take off their mask, when they're eating? And again, I think as infectious disease people, we kind of throw these terms airborne and droplet around. We know that they're very different, but if you're not familiar with those terms, what we're saying is droplet is something that's kind of a bigger particles. Like, if you sneeze, you see those video pictures of the sneeze cloud. The virus will travel kind of as far as your sneeze, and that's the 3, 4, 5, 6 feet that Dr. Weber is talking about, versus other pathogens like tuberculosis, measles, varicella actually stay suspended in the air for long periods of time and can be transmitted well after that individual has left the room. But as far as we can tell, droplet is the primary mode for COVID. And I can answer that question why. As long as you don't have anybody in your, in your 6 feet window, it's okay. And we recommend not doing this for long periods of time, but for up to 15 minutes to have your mask off while you're eating, for instance.
Good, thanks. And I think there are several school districts that have devised special plans around lunch. And those types of plans tend to get developed at the school district level or at the school level. But they've included such attention to detail as my class goes to the cafeteria, we pick up our lunch, with our masks on, we take the lunches back to our classroom, we sit socially distanced from each other, or physically distanced from each other rather, in our classroom. We prepare all of our food, open up all of our milk cartons, get out all of our utensils, and the teacher then tells us, okay, everybody's ready to go. Let's go ahead. We hand hygiene, take off the mask, hand hygiene, go ahead and eat, and not at a pace for anyone to require the Heimlich maneuver, but at no lollygagging, and then put our hand hygiene, mask back on, and then spend the rest of lunch socializing together. Here's a question. Dr. Weber, I'm probably going to go back to you, David, because it seems to be asked from an adult. I have several health issues: asthma, diabetes, blood pressure, and overweight. I'm always hesitant to get the flu shot, especially now. What would you suggest for a person with all of my health issues related to the flu shot?
So it's very simple to summarize the CDC, Centers for Disease Control, and public health recommendations for flu shots. If you're more than 6 months of age and you're alive, you should get a flu shot. So that's the summary. But the flu shot is particularly important because we know, just like COVID, there are risk factors for people who are at higher risk if they get the flu of having severe consequences. Those include people of older age, particularly over 65, people who have comorbidities, underlying medical problems that include obesity, which we didn't know about until the 2009 flu pandemic. Diabetes certainly is another one. Chronic liver, kidney, heart diseases, having cancer, having problems with your immune system, all put you at higher risk of influenza. And pregnant women and people who are immediately postpartum for the 4 to 8 weeks after they give birth are at also higher risk. So all of those people clearly should get a flu shot. The flu shot is incredibly safe. I have personally, because I, for many years, 28 years, took care of the employees at UNC hospitals, I personally have given out more than 100,000 flu vaccines. I've never had somebody have a complication that required them to come into the hospital. And I've certainly never had anyone who had a serious complication that led to permanent disability or death. Really, the only major contraindication to flu vaccine is having had a severe, and I mean very severe, allergic reaction to the shot. There are a few, some more relative contraindications, like getting an unusual disease called Guillain-Barré from the flu shot, although it's actually more common from just the wild type flu. And if you have a severe allergy to eggs, in general, that's safe. But if you had a really severe allergy, then one could give you a flu vaccine that was not made in eggs. So yes, I absolutely recommend that somebody with your medical problems should have a flu shot. And I should say it's not a live virus vaccine. So despite what people say, you cannot get the flu from a flu vaccine. Now, keep in mind, flu is only one of many other viruses. COVID is now another one that can do it. So people who get the flu shot may in fact go on to get other viruses, but they sort of, everyone has this, they call everything that's, cough, sore throat, runny nose, the flu, even though only a smaller number are actually due to the flu virus. And that's what's protected by the vaccine. And I was mentioned earlier by Dr. Smith, we do know that this vaccine is better at preventing death than hospitalization, and better probably at preventing hospitalization than illness. So even if you did get the flu, there is evidence that it can help give you a milder case of influenza.
Great. So a short version is get it. And the more medical complications I have, the more important it is to get it. Thank you. Dr. Zimmerman, I think you're up.
Sure. Dr. Akinboye, there are a couple of questions in the chat about asthma. And can you give us some guidance on what we might be able to do to protect students who might have asthma?
Yes, I can address that. I'm going to assume this is related to both COVID-19 and influenza. I think in general, unfortunately, the winter season can be tough for children with asthma. And what I mean by that is they pick up different respiratory viruses, and those could trigger an asthma attack or increase their chance of getting into the hospital, so severe illness. What we've seen with COVID has been slightly different. So our approach is two ways. I do think that as much as possible, if a child has a defined respiratory condition, for example, asthma or any other chronic illness or chronic disease, if you can protect them and keep them in a bubble, make sure they're wearing their mask, make sure they're washing their hands, make sure they get their flu vaccine this year, those will be the priority. The data that I have seen, they've been very sparse. The data that I have seen around kids that actually do get COVID-19 and also have a history of asthma does not suggest that right now, COVID-19, kids with asthma at increased risk for severe illness from COVID-19. So just to clarify, we will learn more as we go along, but so far, different from all of the other respiratory viruses, especially influenza, we're not seeing a high rate of COVID-19 infections among children with asthma. That being said, I think I've seen too many cases of very sick kids that have asthma coming with influenza. So I'll prioritize getting them their flu shot this year and limiting exposures, particularly to those that are sick. If they happen to be in in-person schooling, make sure they're first in line to have their mask on each time and washing their hands.
Thank you. Dr. Benjamin?
Great, thank you. I think this one is also for Dr. Akinboye. Do you recommend removing carpets from early childhood classrooms? Are carpets considered a surface to result in high transmission of the virus? Remembering that, I think this question may relate specifically to an activity most of us remember, which is sitting down in our square or in a circle during kindergarten. So if you could touch on that, Dr. Akinboye, that'd be great.
I'm a big fan of child development, and I think we have a lot of experts online that can help us with creating the right environment. So I think going back to the science, yes, there are low rates or contamination of surfaces, but clothing and soft carpets are not the highest risk of spread. So I don't know that I would put a lot of effort in removing carpets, but I think we prefer to have surfaces that can be easily cleaned. And unfortunately, I don't think carpets are easily cleaned in terms of just removing mucus or droplets or things like that. So if it's in the future plans to remove the carpets from that environment, then I would support that. I think in the short term, that may not be the highest yield for preventing spread. But as long as it's clean and people have clean hands while they're sitting on the carpet, and it's cleaned on some schedule, say daily or after each large class or after each section of the day, I think that should be fine.
Great, thank you, Dr. Akinboye. Dr. Smith, I'm gonna get one for you. Can you talk a little bit about how we might be able to protect ourselves if we are helping others to blow their nose or wipe their nose, or even helping them with pottying?
Yeah, so, and again, if this is in the classroom setting, so I assume we're talking about someone who's not related to you, not a household contact. I mean, I think it's the same rules that we're talking about. Hand hygiene is the most important. I hear my 3-year-old here in the background. Hand hygiene is the most important thing you can do. And then again, if you're going to be close to someone's face, just wear your mask. Kind of the same common sense stuff that we've been talking about.
Just to add to that, just alluding to last week's webinar on kids with special needs, I think we do realize that it may be harder for them to wash their hands, maybe harder for them to control their secretions, so just spitting or having a runny nose. And in that context, we did talk about having enhanced protection. All that means is a mask and a face shield, and just having some alternative ways to help keep their hands clean, such as using wipes, and certainly washing your hands before and after interaction with a child that you have to come in close contact with that's not in your household. Thanks.
Great, and there's a follow-up question here about how to help children who are not able to wash their own hands. How do we do hand hygiene for them? Dr. Akinboye, I think I'm going to go back to you on this one. Eva, will you pick this one up?
Yeah, so I kind of answered that, and I can reiterate it, just ensuring you have some other way. So if you can help them with soap and water, great. If hand sanitizer is not safe for that child, there may be other reasons. Using a wipe, a sanitizing wipe, or a wet wipe that you can put with soap and water to wipe their hands down would be some easy options. Oftentimes, kids that are not able to wash their hands or rub their hands together with soap and water may not be touching as many things in their environment. Or if they are, just ensuring you're keeping that environment clean.
Great, thank you so much. Dr. Weber, there's a question about neck gaiters. Can you speak to types of masks that may be helpful, in particular neck gaiters?
So yes, there have been a couple of studies with neck gaiters, and we have published one. Duke published a study where it did not seem to work very well, but in our hands, when we looked at our aerosol engineers putting a neck gaiter on a dummy and then on people as well, looking at how well it fit and worked, they actually worked as well in some cases as a medical mask. Again, it all depends on the material the gaiter is made of, and how well it filters out virus and how well it fits. The unfortunate thing, obviously, for the public is, unlike a medical mask, which meets certain standards, and if you go to any store and you're buying a medical mask, whether it's a pharmacy or a store that sells it for hobbies and things, you know how well it works. But in terms of going into a store and buying a homemade mask, you really can't be absolutely sure because of there's not any standardization. So what I would ask people to do is it has to cover your mouth and nose. It should fit snugly around your mouth and your chin. And you obviously want it to have sufficient thickness, not that it makes it difficult to breathe, but that it is filtering. You want to wash it each evening, just in a washing machine and then in a dryer. Ideally, maybe a little bit of Clorox in the washing machine. And most importantly, you need to, as you put it on and take it off, you need to perform hand hygiene because you have to assume the outside might be contaminated. But the short answer was, if the gaiters made correctly, they work very well.
So David, this may be our last question of the evening, which some schools were built in the 50s and ventilation is questionable. How should we proceed? Can you touch on that very quickly about ventilation indoors here?
So we've talked about how, first of all, let me say the most important thing here is wearing a mask. You could have the world's best ventilation system, but if I'm 2 feet away from you and I'm not masked and you're not masked, and I give a good sneeze, no matter how many air exchanges and UV light in the ceiling, that's not going to prevent you from becoming ill. And there's at least one study done in hospital rooms, which had UV light in the ceiling, had lots of air exchanges, many more than a school would ever be built. And yet they still could show that there was virus several feet away from the individual. So that's the most important thing. But that said and done, I think improving ventilation is likely to decrease risk. So what are the options? Well, the first option, of course, is open the windows. If they're open windows, you have some concerns. You want to make sure if you have young children, the window isn't open far enough, someone could fall out. Obviously, in summer months, may make the rooms hot. And as we get into winter, that may make the rooms very cold. Certainly, if there's a lot of noise outside, that can be distracting. And depending upon other issues, you may find smoke and other particles coming into the room. So you have to temper that. The building engineers may be able to do some things by increasing ventilation. It really depends on the age of the system and how well they can do that. And so if they can increase the amount of air flowing in and out, that's certainly useful. They could also potentially, in addition to increasing airflow, put in filters that are finer filters into the air conditioning system, but that actually decreases airflow. So it is a balance. But the evidence shows no matter how poor the air system is, if you wear your masks, you're protected. So I think that's really the major take-home message I want. That said and done, it is worth trying to increase airflow and filtering.
Great. So Dr. Zimmerman, as usual, I'm going to give you the last word this evening.
Thank you, Danny. It's funny how time flies. So it's already 7. We really enjoyed having you guys here today and to be able to talk with you. As we mentioned, the questions that we did not get to will be on the FAQs, will be listed on the website, and we'll try to get to them in future webinars. Next week will be probably a hodgepodge of different questions that people have already sent in. So keep those questions coming to us, and we're really happy to be able to spend this time with you. I hope you have a great week, and we'll see you next week.